to talk about bariatric surgery in adolescents. What I'd like to do is kind of come to a point where you have an understanding of bariatric surgery in this patient population and pretty much how this works out in comparison to the adult population, the things we're looking at and the indications in adolescents as opposed to adult surgeons or adult surgeries. Review the components of an adolescent bariatric surgery program, and we'll go over some of the procedures that we offer as well and their potential complications and the benefits of each. So why should we do this? I mean, that's the most important question. This is a big intervention. And for years, it's kind of been controversial because, you know, these kids are young, a lot of them are still growing, and we wonder if we're doing more damage than good. Well, when you look at the data, it shows that obese children are more than twice as likely to die from either illness or self-inflicted injury as their colleagues or their counterparts that are, you know, not obese. These children, in addition, look at somewhere between 10 and 20 years of decrease in life expectancy when compared to their peers. And we're starting to see in this patient population comorbidities that we usually didn't see in people until they were in their 40s and 50s, which is really disturbing. When you look at these kids from the perspective of cardiovascular risk factors, you know, a lot of them have more than two. And the things that go along with this are very disturbing as well. Things like severe depression, significant hypertension. We're starting to see cardiac manifestations in these young kids. And this is a very disturbing trend. When you look at the comorbidities we're finding, over 50% of deaths that we're seeing right now are obesity-related to chronic diseases. We see hepatic steatosis. And in and of itself, we don't seem to get too concerned about this, but when this progresses to the point where you're starting to see bridging fibrosis, some of these kids are actually progressing to cirrhosis. And we've got children that are needing liver transplants. And it's because this obese state is very pro-inflammatory. And what we're seeing is systemic damage to the organs. And early on, if we address this, we can reverse this potentially. If we wait too long, we see some of the really devastating manifestations of this chronic disease. We were just talking about obstructive sleep apnea, very, very common in this patient population. And we know left unchecked, this can go to severe cardiac disease as well. Cholelithiasis. We were taking out these kids' gallbladders long before we were operating on them for obesity. We're very accustomed to operating on these children. And the gallbladder was the most common reason for this prior to bariatric surgery. It's also disturbing to see that we're seeing an increase in musculoskeletal problems outside of the usual Blount's disease, Skiffies, things like that. I've got a number of kids that I'm seeing for surgery right now that are looking to get hip replacements or knee replacements in their teens. This used to be something we had friends that were in their 50s and 60s that the surgeon's telling them, I can't operate on it because you weigh too much, you need to exercise. They're like, well, I can't walk, which is why I want the surgery. We don't want these kids to get to the point where they're in the same situation. The dyslipidemia, the hypertension, type 2 diabetes, PCOS. A great deal of my patients are referred to me by pediatric and adolescent gynecology because they're having to treat the manifestations of PCOS in this patient population, which is very disturbing for a young girl who's growing body hair where she doesn't want it. She's having painful, irregular periods. These are all things that can be fixed by getting the weight under control. And the most important thing is this fourfold increase risk in cancer that we see in this patient population. I went into pediatric surgery probably for some of the same reasons y'all went into pediatrics. I wanted to help kids. I wanted to prolong their lifestyle, or their lifespan. I wanted to make them healthy. And when I heard that I could, with an operation, add 20 years to someone's life expectancy and decrease their risk of cancer by up to 4 times, I was sold. I mean, outside of emergent surgery where we're saving somebody's life, we rarely have a chance to make an impact on a child's life as we can with one operation in this case. Many of you are probably familiar with this TV series. My wife used to watch it all the time. Doctor now sees these kids or these adults that are really on the extremes of obesity. My 600-pound life. If you're 600 pounds, we're almost too late. We can take a lot of weight off with obesity surgery, but you're losing a percentage. We don't want to take people that are super morbidly obese and at super high risk for obesity-related comorbidities and get them down to a point where they're at not as high a risk but still at a very unhealthy BMI. I'd rather get them when they're morbidly obese with some severe risks and get them down to a healthy BMI where they don't have to worry about it anymore. And that's what we're hoping to do by intervening earlier. Now, recently there was a paper that came out in the New England Journal of Medicine this last spring. You may be familiar with it. Dr. Inge put this out. It was a multi-system study. Texas Children's was also involved. And it looked at the outcomes over 5 years of adolescents in relation to their adult counterparts who had undergone, in this case, Roux-en-Y gastric bypass surgery. The data is pretty remarkable when you look at the comorbidities and the resolution of these, specifically diabetes, high blood pressure, and actually how durable the weight loss is. But I was really impressed with the diabetic statistics, and that's what I'm sharing with you in this slide here. Now, the incidence is a little lower, as we would expect in the adolescent population, but still 14% is pretty high for kids for type 2 diabetes, which, again, used to be a disease of middle age. In the adults, it was 31%. Now, pre-operatively, out of the diabetic patients that were adolescents, 88% of these were on medications, whereas only 78% of the adults were. The interesting thing is that on post-op day 1, none of these kids were on diabetic medications. They didn't require them anymore. I had one patient that accidentally took her metformin because she was used to doing it, and she dropped her blood sugar to the 20s. It's amazing how fast this works. In adults, we still see a remarkable improvement, down from 76% to 26% being on their meds, and those that are still on their meds are actually on lower doses. That's great. That's super, but it's not as good as what we're seeing in the kids. And when we go out to 5 years, 86% of these kids that were previously diagnosed with diabetes no longer meet the criteria for being considered a diabetic anymore. There's always been thought there's no cure for diabetes, but in this case, bariatric surgery is the cure, and that's outstanding right there. So what are we expecting to see? Typically, the average amount of weight loss we're going to get, and remember, some kids will do better, some kids will do worse, is about 30% of your BMI off in the first year. That's about 60-70% of your excess weight. What we're seeing after surgery is about a pound per day for the first 30 days. That's really not unusual. It's kind of the average. What we're looking at in this graph here is if you look at, let's see if I can get this pointer to work here. This is the normal age-related weight gain here. This is what we're expecting to see on the growth chart expanded out. This is what we're seeing in our kids. And remember that morbidly obese kids, the data shows they're going to progress to be super morbidly obese adults with all those health problems related with that. We're going to intervene here with surgery, and we have a significant and rapid weight loss. Now, what we're doing there is we're going from a level of weight at about here where you're starting to develop those comorbidities and those health problems, and we're getting them back down into that healthy range. We're not getting them down to normal, and that's not the goal of this surgery. I'm not going to make Barbie dolls run around the beach. I mean, you don't see those people out there anyway. It's only on TV, right? We're trying to make healthy kids. Now, if they go back on that trajectory they were on before, if they haven't learned anything from the preoperative stuff that we're going to talk about here in a second, and they regain their weight at the same rate they were gaining before, we've still gained some therapeutic space here where we kept them below that pathologic border, where hopefully they've picked up 10, 15 years of life without these comorbidities and without the possibility of these increasing in severity. That's worst case. It's really important, and I try to stress this to my patients when I'm talking to them, that lifestyle changes are essential to their success after surgery. I tell them when I put the last stitch in the operating room, I can't do anything else for them for weight loss except be a cheerleader, right? It's up to them, and we work with them really hard to develop those habits that are going to help them to be successful. So what are the requirements? When you think about adults, every program's different. There are surgeons out there that have different levels of requirements. Some of them may require 2 or 3 visits. Some of them, may not require anything other than a down payment, and they'll put you on the surgery schedule on Tuesday. For us, it's very strictly regulated. The ASMBS and the insurance companies, which are kind of in lockstep with the ASMBS on this, which is a good thing, require typically a minimum of 6 to 8 months of medically managed, physician-overseen weight loss. This is a multidisciplinary approach. We want to look at everything that can be involved with the obesity in these kids. We want to rule out things that can be addressed medically before we proceed to surgery. They're going to work very closely during the entire program with a dietitian. That's the most important part. Just things like simple logging of your food is very important to give them an awareness of how they're eating and what kind of choices they're going to have to make after surgery. It's really important if you go to some place like Olive Garden after a gastric sleeve and you can eat 1 breadstick and be full, Or you can, make some good decisions and say, hey, I need my protein, I need some vegetables, and you've got the tools to make those kind of decisions for the rest of your life. That's a big role of the dietitian in this program. They also get a psychological evaluation. This is vital. We don't want to operate on someone that's not going to be able to comply with the program afterwards. They have to be mature enough to understand what they're getting into, and they have to have a good support structure at home, because we're looking at the patients and their families, because these aren't kids that are going to go out and take care of themselves right away. They need that social support at home, and we evaluate that and make sure that they're a good candidate. Now, the question that comes up with that is, can you do this on, say, somebody with Prader-Willi or somebody that's developmentally delayed? And the answer is yes. Part of that evaluation is going to look at their support structure at home. If they have a good, strong support structure at home where they can support a child with an intellectual disability, then we can proceed with surgery, and we've done this with good results. We like to see them with pediatric and adolescent gynecology. As I've said, they send us a lot of patients because of the PCOS, but it's very important for them to also not get pregnant for the first 2 years after surgery. And what we're seeing is, with that estrogen excess being converted to the testosterone, they lose their fertility, and that comes back very rapidly. In the adult population, this is manifested by people who have been trying to get pregnant for years, suddenly get pregnant without even expecting it, because suddenly they're fertile. We don't want our young girls to get pregnant, not only because they're young, but because when you're losing weight very rapidly, you can't develop a body inside you that needs all those extra nutrients that you're not even providing to yourself. So it's just not safe. So a lot of these kids will opt to have an IUD put in at the time of the surgery, or will be on other sorts of birth control to ensure that this isn't a possibility. Our diabetics see endocrinology. We also set them up with cardiology if they have high blood pressure, ENT for tonsils and adenoidectomies if they have bad sleep apnea, and that's part of the obstruction, the orthopedist for their orthopedic issues. We get them to everybody that they need to see, depending on what comorbidities are turned up during their evaluation. All of this is overseen by both a surgical director, who's typically a pediatric surgeon, that's me in this case, and a medical director, who's typically an endocrinologist, who manages all the medical aspects of the care and answers any questions that might arise on that. Again, our emphasis is on sustainable lifestyle changes during this period. We want to do things that are going to promote their success post-operatively, but we all know that things like crash diets, big extreme lifestyle changes, exercise regimens that are way outside the realm of what these kids would normally do, they're just not durable changes. I mean, anybody else try keto? I did. It lasted 2 months, and then I needed my carbs. And all that 15 pounds I lost came back 25 pounds later, not even a month. I mean, that's a typical course for anybody, heavy or thin. So who can we see? Right now in the state of Texas, Medicaid puts forward that we can't operate on anybody with a BMI of less than 40, and they're pretty strict on that. That's different than the adult population. Typically in an adult, if you're 35 BMI or higher and you have significant comorbidities, you can qualify for surgery. Doesn't make a lot of sense to me that if you're younger and sicker that you shouldn't qualify for surgery, as well as somebody who's older and the same degree of impairment from their comorbidities. I'm actually working with the state to try to get those guidelines changed, because I think it's important to take care of these kids and not make them gain weight, so we can work with them if they're really sick. The age typically is greater than 14 years of age. The important part is that they reach skeletal maturity. And we test this out during their preoperative evaluation by looking at an x-ray of the left hand to make sure the physes have fused. If you have patients that are younger or heavier, it doesn't mean that we can't take care of them. If they're really sick, we usually say send them to us, we'll evaluate them, and maybe with some peer-to-peers and some phone calls, we can get them the care that they need, or at least get them set on the right path. Okay, so here's the poll to see if this works. Have you ever referred a patient for bariatric surgery? Much easier than neurosurgery questions, but you guys killed those, so it probably doesn't matter, right? All right. Excellent. Well, for those of you that have, thank you very much. And for those who have thought about it, maybe we can convince you. All right, so what does a bariatric patient typically go through? The initial visit's a long one. At this point, it's almost 2 to 3 hours. You spend a lot of time talking to the surgeon, who's going to go over what our program entails, what our expectations are, what we want to do, as well as go over the options for surgery, the potential complications, and the risks and benefits of each procedure. Also meet with a dietitian who's going to go over a dietary plan, go over the basics of dietary logging, and give some homework assignments. This can include, 30 minutes of exercise 3 times a week for a start, and a good diet plan based on what turns up during their dietary evaluation. We also have a social worker who's available who will work with them on if they have issues with transportation, funding for food, or even just family support issues. These can be addressed. We also order a whole panel of labs and x-rays and ultrasounds that they can get usually the same day for the majority of them. We put that slip in and they can get it done downstairs. These visits are going to continue for a minimum of 6 months. Each time they come back on their monthly visit, they're going to start off with a dietitian, and they're going to go over their food logs and what their previous homework assignments were. These homework assignments are really important because it helps us to weed out those patients that really aren't committed to the program. If they can't be bothered with logging their food and keeping up with their homework assignments, they're probably not going to stick with the post-op regimen, and they're probably not a good candidate for surgery at this time. That may change over time, and we don't kick them out of the program. But we may say, maybe we need to put off doing surgery at this time until you're a little more committed. The other side's true too. If they're writing stuff down, but they're saying, I ran a marathon yesterday, I've been eating carrot sticks and apples and nothing else, and they've gained 35 pounds, well, then they're lying to us. And if you're lying to me now, you're going to lie to me after surgery, and that's not somebody that I want to continue that kind of relationship with, so we'll work on that as well. That's going to go over for about 5 months. We also offer monthly support groups. For those patients that are diagnosed by our psychologists with binge eating disorder, we have a binge eating support group. And for the rest, we have a group that's run by an organization called Common Threads. What we're trying to do here is teach them how to cook healthy food. If you're like my son who never cooked and goes off to college and he goes to the grocery store, he buys meals. Whatever he can put in the microwave and is done, that's what he eats. And he's gained about 20 pounds since he left the house. If we can teach them instead to learn how to make healthy things, when they go to the grocery store, they stay out of the middle and they stay around the outside where the good stuff is, right? The things with expiration dates. And they cook, they buy ingredients, and they put together meals. Those are skills we're trying to teach during the 6 to 8 months because it's vital to their success afterwards. Additional visits that will happen during this time period, during this 6 months, the psychological evaluation, any follow-up that might be needed depending on the results of that. We'll get a sleep study to diagnose these kids that haven't already been diagnosed with sleep apnea because we want to have that treated for at least a month before surgery, so that they don't have anesthetic complications, and then any other subspecialists that are indicated. So our procedures. The one, we always address diet first. But we also offer the room-wide gastric bypass. Now, this is the oldest operation with the most data on it. This is a restrictive procedure. We're really making a pouch out of the proximal stomach about the size of a boiled egg. That restriction is responsible for the majority of the weight loss. We also bypass a segment of bowel, and it's got a malabsorptive component too. We'll talk about that in a second. The second procedure is the sleeve gastrectomy. This is a newer procedure. It's actually associated with less complications. It's a less radical change to your anatomy, and the results are very equivalent to what we're seeing with the gastric bypass. Currently, about 90 to 95% of bariatric surgeries done in the United States are the sleeve gastrectomy, and it's the one that we primarily recommend to our patients. Looking at the gastric bypass, your mortality is about 0.22%, so it's very safe. It's a little worse than having your gallbladder out, but when compared to a hip replacement or a C-section, it's considerably safer. The biggest issues with this are going to be the effects on the absorption of your vitamins and minerals. It's a malabsorptive procedure. You're going to have to be on vitamin supplementation for the rest of your life. And when we look at the data and how teens do with vitamin supplementation, they do great right after surgery and then they fall off. But when you think of B vitamin deficiencies, the B is the blood, the brain, macrocystic anemias, we worry about Wernicke's encephalopathy, permanent brain damage. These are not things we want to mess with in this patient population. It's one of the reasons I shy away from this. It is effective. At 1 year, they're typically losing about 65% of their excess weight, and at 5 years, it's pretty durable with 60% staying off after regain. Now, the sleeve, the morbidity and the mortality is even lower. It's more equivalent with the gallbladder. The effectiveness is excellent as well. It works a little better right off the bat, about 70% of the excess weight off in the first year. A little less durable because the stomach is just like any other muscle. If you stretch it out, if you keep stretching, it'll stretch out. And if you overeat with this, you'll stretch it out like you never had surgery in a couple years and we'll be back. So we always bring that up, but you don't have the problems with the vitamin deficiencies if you eat a healthy diet after you finish the acute weight loss period. So here's one of our patients here, Ezrine. She's wonderful. I don't know if anybody knows her here, but she was the first patient we operated on up in the Woodlands. And when she came to see me, she couldn't even walk 10 minutes without having to sit down because she had so much pain in her feet and ankles. 1 month after surgery, she came in, she had lost 15 pounds, and she looked at me and she said, "Dr. Stafford, I can feel bones in my wrist. I never knew they were there." It was pretty amazing. At 3 months after, or a month after surgery, she came back and she said, "I just went shopping with my mother. I walked all day and I didn't have to sit down once." She had lost 30 pounds by that point. Here you see her picture at 6 months here. She's doing great. She's going to fraternity parties at the lake, which is stressing me out. She is playing tennis. She's riding a bike. She's never done that before. She's swimming. She's having lots of fun. She's doing all the things with her friends that she used to have to watch them do while they were playing, and now she's taking part of that. And this is snowballing because as she becomes more active, as she has the ability to do that, she's burning more calories and losing more weight. And this is only 6 months into it. She looks fantastic. She's lost over a third of her body weight at this point. There have been some recent things in support of bariatric surgery that have come out. This article in healthychildren.org actually kind of expressed a thought that has occurred to me in the past, and that is, in some situations, maybe waiting until they're teenagers is too long. I've got a boy I'm operating on next week who's in renal failure. He's 18. He's on dialysis 5 days a week. He's had high blood pressure since he was 8, at which time he was over 200 pounds. He's 6'4" and almost 500 pounds. If we had operated on him at like 10 or 11, he probably wouldn't be 6'4". He might be 6 foot, 5'10", but he'd probably still have his own kidneys. In that case, would that be a situation where it might be a benefit to intervene earlier? These are things we're going to look into in the future. I don't really have the answers right now. Ideally, we'd stop people from getting that point in the first place, and if we could figure that out, I'd stop doing surgeries tomorrow. But right now, the best approach seems to be the surgical one when you get to kids this size. Remember, with diet and exercise, a good diet, you'll lose about a half pound to a real radical one, 2 pounds a week. If you have to lose 200 pounds, we're talking 4 or 5 years of strict diet and exercise. Or we do surgery and you have it off in a year. And the resulting resolution of those comorbidities is equally rapid. And I think that's one of the things this has to offer. Thank you.